Good afternoon, everyone. Hopefully everybody's got some food. Really great to see you last day, or day before last, but the last full day of the meeting. It's been great, and thanks for spending your lunchtime with us. I know you have some choices. Let me just back up and introduce the panel. Venita, Chandra. These people don't need any introduction, but I'll just say, we have a full complement of Venita, the vascular surgeon from Stanford; Jay Mathews, the interventional cardiologist from Florida; Mike Siah, vascular surgeon from Texas; and Mike Watts, who is an interventional radiologist. I think Mike, is your actual practice in Philly area, or is it more in New Jersey? I know things melt together in that part of the country. Probably, okay. There you go. So, but each of these folks on their own is a true expert in our field. Here are some disclosures. So I'll just briefly, to get the ball rolling, talk about some basic principles and the concepts around mechanism of action. And so, if you have a multi-thousand-pound rock, the way to divide it cleanly is tap, tap, tap in different places along the rock, and eventually the rock gives way. And we need something like that for vessels, in the sense of, there's been so much talk now about where we've been with angioplasty and where we're going in the future with modified balloons or IVL and other technologies. But I think the bottom line, and I think a lot of people are feeling this, that we need something more than plain balloon, and I think Serrator provides that. And people talk a lot about focal force, but Serrator actually provides point force because the serrating elements actually come to a point and provide a significantly more or larger amount of force, I would say, to the wall, and actually does create some micro cracks, as you can see in this concept here. And this line of serration then becomes the place along which the force is exerted. So with plain balloon, you have an equal amount of force being delivered circumferentially and longitudinally. And when you come up against a complex problem in your life, the idea that you're going to apply the equal amount of force to the entire thing is quite low. You're always going to look for the place where your energy can be exerted most efficiently. And that's what serration angioplasty does. So here's just this concept of the point force, or more focal force than you can get. Here is the comparison of Serrator with plain balloon. Here's some other modified balloons and their ability to exert force at a point. We can see these on OCT. We can see these serrations on IVUS. And with that, we get, in general, way better lumen gain than we would otherwise expect. It comes in a full complement, a full skew of designs from 2.5 to 8 millimeters in diameter and across different lengths. And then now we have the SL Pro, which is being used a lot for pedal angioplasty. We do have data for both the above and below the knee cohorts. And you can also see what the final residual stenosis looks like, way less than 30% in both cohorts. And this, I think, is important because it was achieved at relatively low atmospheres and with a low bailout stent rate. And we also have this concept that when we compare plain balloon with Serrator, the improvement in residual stenosis is substantial. And as you know, the smaller the artery, like BTK arteries, the more important that the size of the lumen really starts to matter. It leads to or provides the ability for greater flow because the radius, the fourth power, is how we assess or how we calculate flow. And this improvement in residual stenosis, I think, is really significant. So we can optimize the lumen, we mitigate against recoil, and we minimize dissection. We're going to go a little bit more into the recoil in a minute, but I'll just go ahead and introduce Venita again, who will take us through that data. Thanks.
Thank you, Peter. Good afternoon, everyone. Just show of hands, who's used a Serenator balloon in their practice? Yeah. I like the point for it. I usually describe it in my lab as like being stepped on by a stiletto versus a sneaker, but that's incredibly impactful. And what I've really seen in terms of luminal gain from the get-go, it's just been a really lovely addition to my portfolio of tools. So these are my disclosures. Peter did a nice overview, but recoil, we're going to focus a little bit on recoil here, and it's a problem. It's particularly a problem in the smaller below-the-knee vessels, and it can be, due to anatomic recoil or functional recoil, such as spasm and the vessel elastin. I think when we talk about recoil, we all go back to this study. The Baumann recoil study has been quoted, I think, just about in every CLTI and below-the-knee presentation. And what Baumann did is he defined what recoil was and did basically a number of interventions with POBA and then did a 15-minute delay and reevaluated for recoil. And he defined a percent recoil with the calculation right here in terms of minimal luminal diameter at 15 minutes and then at time zero compared. What Baumann found was that early elastic recoil was in 97% of the lesions, just really astounding amounts of recoil. And the mean luminal compromise was almost a third. So pretty impactful. And since then, while we keep saying there's recoil, really haven't thought too much about it, haven't studied it too much. And so when we're looking at the concept of the impact of luminal gain that serration angioplasty has, we wanted to actually study the impact on recoil. This is just the data on recoil phenomena. Again, nothing core lab adjudicated, a few other studies here and there talking about it. So this is kind of why we started to do it. So why care about recoil? Peter already mentioned this. Basically, the flow is related to the radius to the fourth. So you have a tiny bit of recoil in a small vessel, and you have a substantial decrease in recoil. So it is incredibly impactful. And this just shows those small increases in diameter can dramatically improve flow. If you can see 41% of possible flow with 20% restenosis, and if you go back to residual stenosis of 10%, you go up to almost 70% volume flow. So small differences in diameter can make a big difference. This was a very interesting study, actually. This has not been published, but this abstract was presented. And what they demonstrated was that if you had recoil, so why do we care about recoil? We talked about flow, but it ended up with substantially increased rates of reinterventions as well. So you have recoil, you're going to need to be treated again, you're going to have worse outcomes. So it is important. We've already talked about the serration technology and my stiletto little pokes inside the vessel. So it was a huge honor to work with Dr. Lichtenberg in Germany and to actually really look at the impact of serration angioplasty on recoil. And what we did was a comparative study in our two sites and compared POBA to recoil. And we did the whole Baumann approach. So we did the time stamp 0, and then we waited 15 minutes, which was, I'll tell you, a little painful in the lab, I'm not going to lie, but worth it for the sake of science. And we did a 15-minute angiogram. This was core lab adjudicated. We had 40 lesions. And again, it was a comparison of POBA versus Serenator in the below-the-knee vessels. The angiographic images pre, during, and post 15 minutes were assessed. Again, core lab adjudicated, and the lesion length was up to 220 millimeters, and the RVD ranged between 2.5 and 3.5. What did we find? Well, this actually really nice little video will answer it. Just going to let it run for a little bit. So this is just showing you what was happening in terms of recoil in the period of time. Obviously, visual, we only did a 15-minute timestamp. But what you'll find is that POBA at the 15-minute timestamp had a dramatically higher rate of restenosis as compared to the Serenator serration angioplasty. Only 6% recoil with the use of the Serenator versus 55% recoil with the use of POBA. So, the concept and the impact of this and the luminal gain really did impact the recoil, and I thought this was pretty profound and interesting data. So just really quickly, I hope everyone's kind of done with their lunch because I've shown some foot shots. This is a very recent case, and I think just again, it demonstrates the impact in terms of luminal gain of this technology. 74-year-old woman, typical comorbidities, actually very recently had an MI and PTCA. She had actually been seen in a outside hospital and had undergone 3 recent angiograms, but yet this foot looks like this. And she was actually told she needs a below knee amputation and sent to me for a second opinion. This is what her ultrasound looked like, and you can see multiphasic till the knee and then monophasic below the knee, a TBI of 0.19 and a PAT class 3. So clearly below the knee disease that was still not effectively treated despite 3 angiograms. This is her angiogram results. I like to go antegrade access for these below the knee interventions. You can see her prior stents didn't look too bad, a little bit of restenosis in one of the stent, and then this is further down, not too bad in the pop. And then below the knee, looks reasonable in the proximal portion, but they kind of go away, and there's reconstitution of what was the perineal artery that caused reconstitution of the dorsalis pedis and the pedal arch. So this is why she was not getting better, right? There was clearly excellent treatment of the fempop area. The stents seemed to be not bad. She actually had thrombosis stent 1, which was one of the reasons for the 3 interventions. But she needs more perfusion to this foot, there's no question about that. So actually, the anterior tibial was accessed and pretty easily because of the antegrade access, I think, crossed. And you can see I get down to the foot, and then I was able to actually cross into that little DP as well. And this is the IVUS imaging, and you can see the sizing with IVUS. You can see the ring of medial calcification here as we go through, but relatively heavily calcified small vessels. So the anterior tibial artery was treated with a 3x120 serinator, and that little focal little spot in the dorsalis pedis in the foot, I treated with a 2.5 serinator, and it went right in there. We serrate and then inflate technique. These are my balloons, and this is the completion. And I'll tell you, I was pretty happy with this result. I don't really think we get this kind of luminal gain with regular POBA. I really think this is quite impactful of the technology and going all the way down and being able to go all the way down in the foot. And what I think you can really see is that the end of where my 2.5 balloon stopped, you could just see the diameter difference there and the impact of that balloon. So she's actually still healing. She underwent a toe amp. She's doing very well. PAT class has improved. So in conclusion, recoil is a thing. It's a real thing. We keep talking about it, but we haven't really studied it to see what impacts it. So I think it's pretty clear that serration angioplasty can impact recoil. We've demonstrated in a comparative study. I'm really impressed with the luminal gain that I'm getting with this device, and I'm going to let Mike take it from here.
That was a great talk, Venita, and that was a nice case. That was really well done. I just have one question. How often do you wear stiletto heels when you do these cases?
Not as often as I do.
Anyway, we're going to have actually time for discussion as well. So if anybody has, this recoil thing, it's one of these things everyone complains about. Nobody does anything about it. And now suddenly we can do something about it. So think that over. And when we get to the discussion, it'd be fun to kind of dig into that a little more. So Mike Watts, take it away.
Yeah, so going to get into a little bit of the pedal interventions that we do with Serinator, and as we kind of talk about this, kind of the idea is why, right? So these patients that we're treating are getting more and more complex. They're further and further along their Rutherford stage, their Wi-Fi criteria. They're sick patients with really bad distal disease, and we've known since 2017, 2019. There's a Korean study that we're quoting here in the Rendezvous Registry that actually treating the below ankle arteries is impactful for these patients and for their wound healing. So just kind of like Venita's talking about, we can get a better result with serration angioplasty rather than angioplasty. So let's see if we can do that in the pedal arteries. So one of the really impressive things about the company is Cajuns a small company, but they said, look, we believe in our data, and let's go ahead and design some studies like the recoil study, and this pedal study, which Ted Gifford, who's like a top 10 quality human being in the world, said, hey, look, I think it'd be really impactful if we can get some people together and do some cases all below the ankle. There's a line there that shows you where the ankle is. And really see how these patients do and follow them, prospectively. So what we did is we got a bunch of centers together, and anytime we used serration angioplasty below the ankle, we evaluated the result, and then we followed those patients. So this is the breakdown of the vessels that were treated. And you can see a lot of them are dorsalis pedis, but we also went to the plantars. And then there's a lateral tarsal artery there just to mix it up. And this is the size balloons based on IVUS. Most of us are using IVUS to size these like Venita showed. And we're using 2.5, 3, and 3.5 millimeter balloons. So this was early on. So this was when the data wasn't there and the SL Pro wasn't there. So we didn't have a 2.0 at this point. But you can see 40% of these patients were CTOs, and the vast majority were severely calcified. So this is our outcomes, and I think the residual stenosis is really impressive. So 13% median, and then the safety. So we didn't perforate any arteries, no embolization. One vessel occluded. There was a few bailouts. But overall, if you start looking at the follow-up, we're talking about more or less 6 months, 5-6 months follow-up. The retreatment was very low, 15%. Amputation rate was very low, and the wound healing was really impressive. So 5 months, 97% major amputation freedom, and then no perforation, embolization, or significant dissection. And these patients went on to healing in what really is the first pedal angioplasty specialty study. So, this is a retrospective study we just talked about. I don't have like some really cool graphic that I can just let play. I have to actually read the numbers here. But, we had really great freedom from CDTLR. We didn't have these complications that I think people would be concerned about having, this 0.4 force technology. And the ballast stent rate was very low and the patients did very well. So this is actually, we're talking about the SL Pro, which Peter talked about. So this is a 2 millimeter balloon. And instead of the 3 strips that the other sizes have, it has 2 strips. So it's actually a really slick balloon. And I was really excited to get to see it. And this is the first patient I had. So, he's got the great toe and a small toe ulceration. You can see how red and angry those small toes are. And he has basically, everything you can, all of your patients have. Been diabetic forever, has had multiple coronary events, he's got COPD, and this is significant pain for him. This thing happens, these go on for months before someone finally sends him. So I think one of the things I want you to see is, Venita had these beautiful Stanford quality images, right? I'm doing these patients in the outpatient-based lab. So as we know, there's no extra reimbursement for Serrator, but for me, these patients aren't really effectively treated, especially these really calcified, sick patients with tibial artery occlusions, until we treat them with serration angioplasty. So if we look through the calf, he's got a perineal that kind of gives some anterior perfusion towards the DP, but we see it's not a real DP. And the posterior tibial is just basically collaterals, and we get down to that ankle, and we see a little bit of that lateral plantar come back, and don't see much of anything else. But what we do see is that the posterior tibial is feeding the forefoot. And so I think that's a pretty good target for what we're going to do here. So as we kind of cross and get down here, and again, I'm showing you how we do this, outpatient lab images here. We get down, we get our wire through the through the occlusion, which is pretty calcified, but we work our way through. And then this is the Serrator. This is the 2x120, so SL Pro. So first, I did the posterior tibial artery, and we kind of go low and slow, and we keep it up for a couple minutes. And then I thought, look, this guy's got, in my view, he's got both, kind of forefoot and hindfoot perfusion issues, right? Because he's got a great toe and he's got small toes. So I'm like, all right, I want to get as much flow down through this loop as possible. So I just send the balloon down through the lateral plantar artery afterwards. And then this is the kind of result we get. So, this lateral plantar, I don't think it was going to give him enough perfusion to get him to heal those wounds. And now when we inject, we still see that AT perfusion, or that perineal forefoot perfusion come down, but it's way outpaced by this big, beautiful posterior tib. We come back up through the perforating artery there, and we start having some forefoot perfusion through here. And this is actually a beautiful result. You can see a little bit in the common plantar artery. There's still some calcium there, but everything looks really good. And the important thing is that, this guy has gone on, so this is now a year later, and it's a lot of fun for us because all he wants to do is, he's one of those guys that just, I want to hear the sound, I want to hear the sound, I want to hear the sound. So we listen to his Doppler signals. He's really happy. But this is something that we just kind of wanted to add on because we have never had reimbursement for pedal artery interventions. So CMS is scheduled to publish the final rule for 2026 tomorrow, but it's available but not published. And now, in addition to the iliac segment, the femoral popliteal segment, and the the tibial pedal segment, there's also now pedal reimbursement. So there's another segment, and we're treating these patients all the time, right? So now we have a study that says, look, we have a balloon that works here. We're treating the anterior tibial artery, and we're treating the dorsalis pedis as well. We're treating the posterior tibial artery, and we're treating the lateral plantar as well. We now have add-on codes that are worth significant amount of RVUs. So 11 RVUs for a patent but stenosed pedal artery is 11 RVUs, and for a complete occlusion, it's 13.7. 13.7 is similar to a femoral popliteal angioplasty. So we are getting now, the work that we are doing, and the results that we are having is now being recognized by CMS. And the full payment details will come out in this probably tomorrow or in the next week. But now we have proof that what we do works, and now we have a little bit of an incentive to continue to do this work that we've been doing. Thank you.
Can I just want to make a comment on your case, because I think you flew through something I think is very important and unusual, which is you first treated with the Serenator proximally, deflated it, and then advanced it more distally. And I'll tell you, this is one of the only balloons that I think you can do that. In fact, I often do that. And it's that luminal gain. I think it's a lack of recoil that allows you to do that.
It's just a second nature to me. I mean, I really do that quite often. It just is, you're right. It's not only is it the lack of recoil and the luminal gain, but it actually rewraps quite well. So you are able to do that.
And maybe could we spend just a minute and talk about technique? I know we have an awful lot of expertise up here at the table. Mike, maybe you could start us off. Can you give us some ideas around, say, for example, advancing the SL Pro into the foot? What kind of, that's a big change for us. That's a recent addition to the portfolio. So tell us what your experience been so far.
Which Mike?
I meant Mike Watts, but I know both you guys do a lot of this, as does Jay, as does Venita. But
yeah, I think, especially the SL Pro, I think the concern was, hey, this is going to be, there's going to be a lot of resistance. It's going to be a lot of pushing, I think that we all set ourselves up for success. I mean, Venita showed an integrated access. We use integrated access for basically all of these patients. So, we are setting ourselves up for success, but, advancing, anywhere where the wire is, especially the SL Pro, like I said, mentioned, it's got the two strips of stainless steel rather than three, really has not been an issue. And if it is, inflating it first and then sending it down a little bit further, tends to work every time. So, I have no concerns with this. They come down into 2 by 20. They're very small. We can basically, go all the way around the arch of that without, really having any issue.
Yeah. Other Mike?
Yeah, I would say that the engineering changes to the balloon and the catheter and the tip over the course of the last several years have really, really made this technology increasingly deliverable. I'm going to be honest. I'm going to say the initial iterations of the balloon usually required a lot of angioplasty, pre-DIL, or atherectomy. But kudos to the engineers. I don't find myself struggling to deliver the technology in the way I used to.
Very good. So why don't you go ahead, Mike, to the podium and give us your algorithm, because part of the algorithm challenge is kind of knowing when to do pedal angioplasty. I think we're all struggling with that. One of the big downsides for me is always this idea, well, if I do go into the foot on any given patient, what happens if I create a problem? And I think this device is much less likely to create, say, an abrupt vessel closure or severe dissection, et cetera. Yeah, go ahead, Mike.
Yeah, so these are my disclosures. So interesting. I thought there were going to be more faces than that. So why Serenator? Mike Watts alluded to this gentleman on the screen right here. This is Ted Gifford, apex human. But there are also the people on the panel, right? So why do I use this technology? It's because of everything everyone's already said, right? Dr. Schneider talked about the mechanism of action of how this therapy works, its initial studies of how you were able to get fantastic luminal gain with low pressure. Venita talked about recoil. Again, this is the only specialty technology that's looked at recoil, right? Which differentiates it from all the other therapies. Mike shared Ted's results, or our collective results, on its utilization below the ankle. So when I think about a technology that's been studied in the areas that are important to me in my CLTI patient population, I think about the data that's been generated, and I think about the messaging that we've already heard today. And as a result, I think about using this technology routinely for all of my patients. And this is the bottom of one of my patients' foot. I actually did this case the week before coming here. So classic comorbidities of these types of patients with non-healing CLTI, non-compressible ABIs bilaterally, toe pressure 28, TBI of 0.2, utilizing Wi-Fi. This patient's 231. It's Wi-Fi 4, and the benefit of revascularization in the setting of ischemia is high. So looking at this patient, no aortoiliac disease, no femoral popliteal disease, but as you'd imagine, some extensive below-the-knee disease. You can see an occlusion of the anterior tibial artery at its origin, single vessel runoff via perineal artery, and the wisp of the origin of a posterior tibial artery with reconstitution of what looks to be an anomalous dorsalis pedis and a lateral plantar artery down below. So went after the posterior tibial artery, and like everyone has shown, IVUS is a really important tool that I use routinely before I treat any patient, just for sizing. I think it's fantastic for the trainees, and it really helps me determine how to appropriately select the tools I'm going to use. So this patient down distally, their lateral plantar artery was 2.7 millimeters down below. So we ended up using a 3x120 Serrator balloon repeatedly over the length of that posterior tibial artery, the anterior posterior tibial artery, yeah. And you can see fantastic still images, excellent result with wound blush going down all the way to the foot, right? And this didn't require any atherectomy to precede it. There's no pre-dil. This is, a standard typical long segment CTO that we see in patients with critical limb-threatening ischemia. And this is another more unique case, and this is kind of tells the sort of sad story that affects some of these patients. 75-year-old lady with hypertension, coronary artery disease, type 1 diabetes, AFib, with a left hallux plantar ulceration secondary to a joint contracture, right? So she had arterial non-invasives that are kind of borderline, an ABI of 0.66, toe pressure of 44, Wi-Fi 211, moderate benefit of revascularization if you just look at the foot in and of itself. So intervention was deferred for this patient, and she underwent IP joint arthrodesis with podiatry, and you can see here is a horrible, horrible looking foot after surgery that became gangrenous. So she ultimately underwent angiography, and again, no femoral popliteal disease here. Two vessel runoff via posterior tibial artery and a perineal artery, and a long segment anterior tibial artery occlusion. So again, these types of situations are challenging because if you rely on arterial non-invasives, sometimes you can be fooled into thinking people are going to be able to heal their wounds or heal podiatric interventions and stuff like that. But when a foot looks like that and the patient's under duress, it's very, very easy to take them to the operating room to do an angiogram. So once again, we cross this anterior tibial artery CTO, again relying heavily on IVUS for our sizing. This time it's measuring 3.2 by 3.4 distally. And this is a nice video of us primarily using Serrator. So on the right-hand side, you can see, again, a long segment CTO, no pre-dil, no nothing. That's me delivering the balloon across this long segment tibial CTO, and it's not requiring pre-inflation up top. It's just going all the way down. And again, long segment angioplasty using a 3.5 by 120 Serrator balloon. And the angiographic result we all hope to see after we treat these types of patients, with wound blush going out to that wound. And follow up at 1 year, you can see a persistent increase in the patient's TBI with complete healing of that wound. And then another case of 78-year-old patient with COPD, AFib, CKD, type 2 diabetes, and a non-healing left hallux wound with a BMI of 55 and non-palpable pedal pulses. And again, another long segment anterior tibial artery CTO, I use it in other blood vessels too, but it sometimes feels like it's only the AT. So long segment ATCTO, a short TP trunk occlusion, the PT's occluded, the pedal loop's intact. So naturally, based upon angiosome or angiosome woundosome-based revascularization, I crossed the AT because I wanted to revascularize the portion of this arterial bed that would go directly to the wound. And you see again, luminal traversal of the wire, IVUS demonstrating that 360-degree medial calcific burden. Distally, the vessel was measuring 2.5 millimeters and proximally 4 millimeters. And in these types of situations where maybe I might have pulled a tapered balloon to address that difference in size, I think that one of the fantastic things about a Serenator is that you're able to get luminal gain at very, very low atmospheric pressure. So I used a 4120 to treat the entire length of this ATCTO, just multiple inflations for 3 minutes at 4 atmospheres. And someone might think it's crazy to use a 4 millimeter balloon below the ankle, but I'll let you decide. Fantastic angiographic result. And again, what we all aspire to see, wound blush and wound healing. So in conclusion, my algorithm with Serenator is I'm going to try my best to cross luminally, and if I'm able to deliver therapy, I always use IVUS. I like it because it helps me identify what I'm treating and what size tools I need to optimize my therapy. And Serration angioplasty facilitates low-pressure specialty angioplasty that avoids the shortcomings of conventional PTA, right? So we don't see recoil in the same way. We certainly don't see dissection in the same way. And because you're using low-pressure angioplasty, you're never really ever encountering things like a tibial artery perforation. After you've done that, I like to use IVUS. And in a perfect world, I think drug elution is going to be something that is going to play a really big part in taking care of these patients. So I think serration angioplasty with subsequent drug elution is going to be a mainstay of therapy going forward. Thank you.
Thanks, Mike. Those were really great cases. I'm wondering, shall we see, does anybody have any questions? You've seen a lot in these last few minutes, from recoil to pedal angioplasty, and now some amazing cases with the concept of an algorithm. So please come up to the microphone if you have any questions. Yes.
Would it be fair for me to say that I would use, for very calcified lesions, IVL, for anything else, Serenator? You would think it would be a good assessment of a...
I don't know. What do you guys think? How calcified is calcified to the point where you absolutely have to have IVL? I don't know, Jay.
I just did a case literally right before I came to this meeting where we were convinced we're going to have to use IVL, but I said, you know what, let's give it a shot. And it was a BTK lesion, and a serration angioplasty yielded. I ended up using BRS afterwards. So it was really nice. And if you're going to put a biresorbable scaffold, you need good luminal gain. So we confirmed with IVUS that there was excellent expansion. So the idea that you have to use IVL is probably not entirely accurate. I think there are certain cases where I think IVL can be beneficial, but what we found is that in many situations, when there's even heavy calcium, the serration angioplasty can be effective.
Yeah, I definitely think there's a place in the perfect world, and to be honest, I'm fortunate enough to be in an environment where I don't have to worry about cost too much. And so in those really heavily calcified vessels, I like IVL at a very low pressure to just give the energy, and then I like the Serenator to really get that luminal gain and sort of seal the deal. I think I personally almost always will follow IVL with something, but again, that's adds cost.
I don't think that, what I'm going to say next, anybody would thought, 6 or 8 years ago or 6 or 8 months ago. But I think that sometimes you're going to be able to use the Serenator balloon and cross a heavily calcified lesion or a very badly calcified vessel where sometimes the IVL will not actually reach. So, you may find that as well when you get really distal in some of these bad arteries. The crossing profile sometimes is actually better.
Yeah, I think that we don't always see patients who have just isolated tibial disease. Most of the time when these patients have multi-level disease, those are the types of CLTI patients you're going to see. And sometimes if the patients have extensive calcific burden, you're thinking about opening 2, sometimes 3 different IVL balloons to treat the SFA, the POP, and the tibials. So something that's really changed my practice has been the Javelin catheter, because it allows me to deliver IVL selectively, and then I can follow that up. So I can use a little Javelin in the SFA POP as well as the tibial, and then follow it up with serration angioplasty. So I sort of, get to pick and choose and use things synergistically.
Interesting. Okay, so let's go to Jay Mathews. Jay is a co-PI of the Point Force study, and he's going to talk about data we have in that study so far.
Yeah, so this concept that we just talked about here, using Javelin and whatnot in combination with serration angioplasty, these are the kind of questions that we want to answer. And the Point Force registry was developed to be really kind of more of an all-comers registry to incorporate lots of different types of lesion sets and see real-world utilizations of Serrator in multiple vascular beds. These are my disclosures. We've already talked about a lot of the data that has been presented previously that supports the mechanism of action of serration angioplasty. And we talked about prelude of both the first in human and also the BTK experience, which showed very high freedom from reintervention at 6 months as well. And then also the sub-analyses as well, too, of serration angioplasty versus POBA, showing better flow and improved stenosis. Also the recoil substudy, which showed much better response when it came to recoil. And we also have the pedal retrospective study that's currently under review, which should show a high degree of freedom from reintervention at 6 months as well, and also wound healing. So if we look at the overall Point Force study overview, Dr. Siah and myself are co-PIs of this study. It's a real-world procedural outcome study of serration angioplasty for multiple lesion morphologies in both peripheral arterial disease, and also we have an AV fistula subgroup as well. So these are Rutherford 3 to 6 patients. Also patients who are undergoing PTAB and DVA procedures, and also pedal procedures, as we mentioned before, in addition to AV fistulas are going to be included. And ultimately, we want to demonstrate luminal gain, safety, and also complex lesion subsets, just as we talked about here too, where you might have to use combination therapies. These images will be core lab adjudicated as well too from the Yale research group. These are our faces, but these are all the sites. We have a large number of sites around the country, including some of our panel members here as well too, participating in this registry, and it's enrolling fast. So what are we seeing in the real world? So we're seeing patients that are even more complex, even more calcified, long lesions, CTOs with high-grade stenoses, mixed morphology plaque along with heavy calcium, and the utilization of a lot of different types of tools like we talked about with combination with IVL therapy, atherectomy, and other types of devices as well. So synergistic utilization of serration angioplasty seems to be the overall theme. So if we look at this snapshot from the registry thus far, we're seeing about 64% of these patients are male. Most of these patients are in their 70s. They have the usual set of risk factors. They're hypertensive, have dyslipidemia, they're diabetic. Most of these patients are smokers and also have CAD as well. And a good portion also have CKD, and a lot of CKD patients are excluded from a lot of other studies. And you can see that most of these patients are Rutherford 5 patients with a small number of Rutherford 6. And these are obviously very complex lesion subsets. So the lesion lengths are long. So these the mean lesion length is 125 millimeters with high-grade stenoses of over 90%. Almost half of them are CTOs, and over half had moderate to severe calcification as well too. And you can see on this chart where the locations of these lesions are. Most of these are within the SFA and also BTK segments, with a spattering of cases in different subsets. Now, the 7 and 8 millimeter balloons were just recently released, and they're slowly rolling out. So we will probably see more cases going into the CFA and also into the iliacs as well. So look forward to seeing information from those experiences as well. 53 patients, challenging BTK lesions. You can see that the mean lesion length here was about 115 millimeters. So again, a long lesion. Contrast that to some of the other experiences that we've seen from other BTK series, which have been fairly focal lesions. High-grade stenoses, over 90%, half of them CTOs, and again, over half with moderate to severe calcification. And you can see the broad distribution of lesions. I think we're going to probably start to see some more pedal use as well, too, with increased SL-Pro adoption. So thus far, what we can tell is that the therapy seems to be effective. So if we look at the lesions, they're again high-grade before, but look at the post serration angioplasty results. So less than 20% residual stenosis here too, and bailout stent rates remain low in the ATK experience. BTK also very excellent, only 6% residual stenosis post serration angioplasty with a very, very low rate of bailout stenting. If we look also at dissections, dissection rates, significant dissections, type D to F, very low in the ATK experience, no perforations, no embolization. BTK experience, no dissections at all, no perforations, and no embolization. So this is very reassuring in terms of the safety of this device. So when we look at algorithms, and again, this is also going to define future studies as well too, in a significant portion of cases, so about 80%, serration angioplasty was used as a vessel prep tool. It was also very commonly used before drug-coated balloon therapy, which seems to make a lot of sense. In the BTK space, it was used as standalone therapy because we don't really have a lot of other options in the BTK space yet. But in 80% of cases, it was used as the definitive therapy, and therefore not a lot of other tools like BRS was required. AV fistula, we don't have enough numbers yet, so data is forthcoming as the registry grows. So if we look at the growing body of clinical evidence, there's a lot of sub-analyses we want to look at. We want to look at, obviously, the complex lesions. These are patients that were excluded from a lot of the other trials that are out there, both ATK and BTK, challenging lesions as well, too. So we're looking at patients with CLTI, dialysis patients who are largely excluded, a good representation of females who have largely been excluded from other studies as well and are underrepresented. We want to look at CTOs, long lesions. Most studies use lesions less than 100 millimeters. We want to look at ISR, heavy calcium, and also eccentric lesions as well. So as the registry fills up, I think we'll have a broader understanding of this, and this will also help inform future studies and analyses. So ultimately, at the end of the day, serration angioplasty has been shown to be safe and efficacious, mitigates recoils, and we're really interested in these patient-driven outcomes. You're able to get luminal gain with low pressure expansion, and it is versatile across multiple morphologies, not just heavy calcium, but also fibrotic plaque as well, too. Thank you.
Nicely done. That was quite a nice summary of that data, and it's great to see it developing with all these different subgroups, the people we worry about, the dialysis patients, the long calcified occlusion, et cetera. And I'm wondering, Jay, in terms of obviously you're involved in this trial. But I'm wondering, and I know you see a lot of devices, a lot of early stage devices, and you have a lot in your practice. I know whenever you're not here, you're like doing cases till 10 o'clock at night every night. So I'm wondering, where does Serrator land right now? Let's say it's not a study patient, because I know you do a lot of studies. Where do you use it in your algorithm, say, for above or below the knee?
So, I was a big believer in scoring. We did a lot of atherectomy, and then we'd use other vessel prep tools or plaque modification tools. So I did a lot of scoring balloon angioplasty, and largely a lot of the scoring balloons have been eliminated because I moved on to serration angioplasty. And the reason why I switched is because I found less recoil, better luminal gain, better expansion, especially in calcific lesions, where I felt that some of the other devices just kind of fell short. There's lots of different technologies out there like UltraScore or AngioSculpt and all these other things. And I've really kind of adopted this as my primary modality. What's interesting is that I think a lot of us are doing a lot less atherectomy now than we did in years past. We're doing more IVL, maybe just, standalone therapies, because the data, unfortunately, has not been, that robust. When we need debulking, I think we do it very selectively. I've really used this as kind of my primary modality and then combine it with drug-coated balloon therapies. And with IVUS, I can prove that I actually get very good results. So I think that's an interesting thing too. So I've had a change in my algorithm above the knee and certainly below the knee, I think, where we can go with, perhaps with either primary serration angioplasty or maybe pre-balloon first and then go with serration angioplasty and get very nice results.
I have to say, I'm glad this is the first time hearing about the point force registry, but I'm really glad you're including AV fistulas. I think this is actually an incredibly powerful tool in the sort of venous scar as well. And now that we have the right sizes, I'm excited to see that data. I've been using the Serenator balloon in my DVAs and the pedal arch very effectively as well. So I think its impact on the venous standpoint will be really interesting to see as well.
And I think it seems like in a lot of practices, it's become kind of the preferred BTK tool, because typically with BTK, you're talking about, and I think you said it, Jay, we don't have as many tools, so it very often is definitive therapy. And this is, of course, where we see recoil. And I don't see recoil very much in the SFA, but yet, when I'm doing a long segment tibial and I go to and I get a beautiful result, then I go to the next vessel. By the time I'm finished working on that vessel, the first one doesn't look so good. So, and we've all had that experience. So in that sense, that waiting 15 minutes to do the angio, which is so excruciating, we've each had those momentary. Now I don't see that with Serenator, and you can typically see. And I think you mentioned this, or maybe Mike Siah mentioned it, that you can see where the end of the angioplasty was, because you're actually creating a lumen that is a little bit surprising. I don't know what's going on with recoil. I don't know what you guys feel. I don't understand why we get it more in the tibial and pedal vessels and not more proximally. Is it the type of calcification that typically resides there? Is it just that it's more noticeable because these are smaller arteries? Anybody have any theories, Jay?
I think that medial calcinosis is a real important factor when it comes to recoil, because just simple balloon angioplasty just doesn't impact that. And so if we can modify that in some fashion, I think the point force does create microfractures. I would love to see micro CT of some of that, and I think there are people interested in doing that further. I think that's also the target for the IVL crowd as well. So, I think we're able to achieve, some of these IVL results, and I think it's better than IVL because it can do more than just simply modify the calcium.
My suspicion is that it's there in the FemPop as well, but not as visible, and perhaps because of the larger diameter, not as flow impactful, right? So that's probably why it's just so much more of a tool in the below the knee space. But I find that the pop is, it's very noticeable recoil there as well. So I've had really great results with using this technology there.
Interesting.
Yeah, I think we've all experienced what you're talking about, treating a vessel and loving it, and then, going back, treating something else and seeing, that disappearing. And it's funny, what I was actually thinking is looking at Mike Siah's cases, case after case after case, like these are beautiful, beautiful outcomes. And then because of, data provided by Venita and we actually have confidence, right? You look at it and say, yeah, that's going to be durable. And then we have the data, really back it up, and we see the same thing from vessel to vessel intraprocedurally. And since I've been using it, is basically my definitive therapy below the knee, treat lots and lots of CLI patients. We do lots of long segment tibial reinterventions, and I'm definitely that 2-week mark where we get the first duplex. I'm definitely seeing that these patients are doing better. There's a lot less kind of interval elastic recoil in that first 2 weeks, where we have to kind of go back and decide whether we're going to go back and retreat it or not.
Yeah, Jay?
Yeah, I totally agree. One other thing too that I find really interesting is my decreased perforations in heavy calcium cases. So sometimes, especially if you're going subintimal, and then you get all that recoil in that subintimal segment because of the calcium and also the fibrotic tissue. many times if you put a stent in, you'll have that stent regret. You'll have that area of under expansion. Then you'll go with a really high pressure balloon, and the next thing you know, you've kind of ripped a hole in the artery. And usually prolonged angioplasty works, but I've really seen a lot less of that too with use of the serration angioplasty, because I feel like it's less barotrauma that we're achieving there.
Does anybody have advice about how to get started with it? Is there a certain kind of case you look for? It's user-friendly, so I don't know. Anything there, guys?
Yeah, I would say it's incredibly intuitive to use. At the end of the day, you're able to do something special with technology you're very familiar with. If you use a PTA balloon, you're going to be able to use serration angioplasty. That being said, it's certainly more robust. There's more going on with the technology than a conventional PTA balloon. So because of that, I understand why some people have described some challenges in delivering it to different locations, but, I think about it routinely for every tibial case, 100% of the time. But I don't use it that often for ATK cases. I don't see it that often, but it's not too difficult to deliver.
Yeah, I would echo what Mike said. You just have to use it. I think it's really the most sort of satisfying in a long CTO. And there is a wow factor. I just guarantee it. Like, you will be like, whoa, that vessel really opened up and stayed open, when we're used to what things look like after just conventional balloon angioplasty. This is a very visible difference.
Yeah, there's a zone for me that's probably right at the knee joint. It's probably 4 centimeters above and 4 centimeters below. And when I see, a stenosis, an occlusion, basically of any length there, that's not, we can use it in like really complex popliteal occlusions. But when I start seeing those focal, kind of P3, kind of coming down into the trifurcation, and maybe the TP trunk and at the genu of the AT, like, these things do so well. And a lot of them on IVUS are extremely fibrotic. And it's just you get such a visceral reaction when you do the post angio on those, and that's what gets you hooked. Like, everybody in the lab, when we do the runoff around the knee and they see something, like, all right, well, what size is it? I was like, hold on, let me get the IVUS. But we just know that's going to be a really, really kind of rewarding serenator lesions. That's where I would start. Just basically in that kind of P2, P3 proximal tibials, size it with IVUS, and just basically go 1-to-1, a nice slow low and slow inflation. Make that your first time, and you've set yourself up for success.
What about scenarios where maybe you have to really watch out, or maybe what not to do? I'll mention one that I noticed, especially if you do a really long balloon and you're going to be in the anterior tibial artery coming back up into the pop, and it's a really tight angle. So if you have extreme kinking there is probably a small risk that you can occasionally rupture the balloon. So I've oftentimes gone with the shorter balloons there, or made sure that I was actually deeper within the vessel itself too when I've done the serration.
Good point, Mike.
Yeah, I was going to say, I don't know the engineering behind it, but there definitely was, a period, 2 or 3 years ago where if you have, angulation, whether it's coming up the AT or coming down. For me, a lot of times it was coming from the distal PT through the common plantar to the lateral plantar, and you had some sort of angulation.
SL Pro got rid of a lot of those problems, though. So
yeah. So it's the kind of redesign as far as how those, I think, strips are kind of attached and packaged have really kind of reduced that. But there was a period where I think a lot of people, as the balloon was really becoming more popular and we were starting to get data and people started to use it, sometimes people would start and say, well, I don't know, this. I tried to go around the AT and this balloon started leaking, and I'm not going to use it anymore. I think that's changed a lot, our experience.
I've also had some pretty good experiences in the common femoral. In the distal, you get a long segment, external iliac that's heavily diseased. I think it works pretty well there. Endarterectomy is still my go-to for common femoral, but there are plenty of patients that are too old, too sick, have too many levels of disease, whatever it is, and we end up with angioplasty. It's just a place where plain balloons don't function that well. It's impossible to totally protect the leg with atherectomy, et cetera, where Serenator works well. It's quick.
The Profunda actually works really great in. I've started noticing it because, sometimes you have those patients where, I'll do a combination of a profundoplasty with DCB, And I think that, for some of these patients where it can actually be very impactful for them because that's the lifeline of the leg, really, really nice results. And IVA shows that they get very good luminal gain.
Yeah, I was going to ask, maybe Jay could corroborate this, but when we saw the point force data and that there was a number of lesions that were, treated before DCB, I mean, so that's, when I have someone who needs their common femoral treated and it's, really calcified and, they're not a good surgical candidate or, whatever it is, I will use, whatever 6 millimeter, now 7 or 8, whatever IVA says, use the Serenator and then follow it with a DCB. And I think that's, kind of the best thing we can do at this point.
Yeah, I think the sessions are going to come up again in a few minutes, so I think we'll call the session to a close. But I want to thank everybody for coming. Hope you got something good to eat. Hope you're powered for a great afternoon. I want to thank the panelists, Jay and Mike. Thanks for running the study. You're doing a great job. Mike Watts, thanks for coming. Thanks for your insights, and Venita as well. I got to visit Venita, I think, one of the early times when you used Serenator. That was a lot of fun. It's always fun for me to see another OR or another institution how it works, and you didn't have stilettos on that day, so I'm assuming that. Anyways, but thank you so much to everybody for coming, and have a great rest of the day.